So I'm here with my diagnosing physiotherapist and friend, Anne Florence Plante, who's in France, in Marseille. How are you?
Well, this morning is a nice morning. It's sunny in France, very cold, chill,
Yeah.
and very happy to have you on the Zoom. That's very nice.
It was great
Well,
to.
you're doing a great job. I mean,
Oh, yeah. Well,
I'm very proud.
yeah, thank you so much for, giving me that job. I had 15 minutes in the day that, and that was like 1 minute there and 1 minute there. I was so really bad then, the fatigue. I couldn't think. And I thought, oh, I just knew I was going to write to all the professionals in your notes, and they were going to say, no, you can't use our notes. I thought I'll just write to them and they'll all say no, and that'll be the end of that. And of course, they all wrote back, Eric Bertrand and all of them wrote back and said, oh, you must do this. The way we met, obviously, I was undiagnosed. Everyone was looking mechanically. 5 minutes, these two words came together, Pudendal Neuralgia. And after 4.5 years of being lost, for me, it felt like I was in a non-English speaking country. No one could understand my language. And suddenly I landed in this English speaking country, and you just nailed it. Is there something that you can tell us today about, we're making progress with this? What is the news on pudendal neuralgia?
My feeling from being now back in France and working with the team of Aix-en-Provence is that we have shifted a bit from a condition of entrapment, so pudendal neuralgia with entrapment, and with a nerve that is under compression, and so need to be de-roofed or need to be free, to another sort of symptom, and that would be an array of different symptoms, such as myofascial syndrome. So we are really moving towards this, which might be someone who have done a lot of bicycle and have been making his nerves suffering. But the pain that is sustaining would be more due to muscle contraction or muscle myofascial inflammation and a sort of muscle cramp, and that come back to treatment that was done in Australia. So 2004 or something like that. I think Thierry Van Kai was already talking about those muscle, and with the physio Sharon Jarvis was doing a research on Botox and had to ease those muscle. And I think we are going more and more this way, which means that there would be less and less surgery, probably a milder surgery, I would say.
Yeah, I remember lots of work, entrapment and lots of surgery. But I remember the surgery, to sort of shave the nerve or whatever. Lots of that, and still lots of people are having that surgery. But I also remember you saying to me that in Australia at that time we didn't inflict pain to relieve pain, because you sort of. I remember you saying those things. And yeah, of course, nerve blocks and I mean, we definitely got into that. We were so against surgery in Australia, but
Okay. Yeah. Well, Australia always been cautious when there is no randomized controlled trial or when there is no proof of anything. So I think it's quite a wise way to go, which Australia is. You would say then it's a bit slow, but in a way it's a bit safer.
Yeah.
And I really have a feeling that surgery would be really what you would do when you have really be unsure
Yeah.
that there is no other avenue.
Sure. So if I was saying to you today, let's take the scenario, it's been like I said, 9 years down the track. I'm building my PainTrain. I'll walk in and I'll show you, I've sent you my link and you've seen my history. What would we do? Would we do anything differently? Would it be to the pain specialist? Would it be physio? Would we use the same language? What would it look like today? Would it be different?
I think what for me has been really a change is to learn how to talk to patients. And I think Lorimer Mosley have been really helping us to understand the sort of neuroscience behind pain and how we can talk in a simple way to patients and explain them what's going on, and giving the education and giving the patient a sort of control on everything. So that's really one thing that I think I have moved to, which I was already doing that in Australia, but clearly this is how I will set. I will say, okay, Soula, so give me all the MRI, give me everything that you have done to look at these problems, and then I will question everything else. Like I will question your bladder, and I will question how it's bowel movement, and I will question your sexual life, and I will question sport that you are doing and the impact of the pain. And so I will take an hour of trying to understand what is this pain and what different silo it's sort of acting. We have moved from a very focus sort of treatment of pain to a wider approach and just questioning the patient about everything that is impacted.
Yeah, I remember that. I mean, there are so many valuable things. I did the video with Theo today, and actually he mentioned you. We mentioned you quite a few times because he was saying how the things that he learnt from the appointments, from him being there, and how much you helped him also. But I remember the bladder, that the investigations we did, you know, drink the water, I think it was a full glass of water, and then pee in my little pan and measure it, you know, and I just thought, what are we doing here? I mean, on the first hour, you know, there was not even anything. And then by 3 o'clock, I had a liter of water in my bladder, and I had no idea because I didn't feel like I needed to go to the bathroom. And so you all that awareness, but you were always very direct in your communication is like that. And actually, I should really say too that it was Lorimer Mosley. I was desperate, you know, I was lost, and I did write to Lorimer after starting to read all of their education, and said, look, can you help me, or can I help you? Can I be some kind of, I don't know, example or, you know, research? And he said, go and see Anne Florence Plante, you know, at the women's. So he was the one that led me to you. And then, you know, I remember I said to you, I feel like I've got my finger stuck in the PowerPoint. I used to say this to everybody, but when I met you, you said that sensory pain. Like you had all those words, you know, you it was like a dictionary.
Working still the same with the patient I'm seeing in France now, because they arrive with those symptoms that are really odd to tell to someone. It's like I have a pressure, I feel like I have a golf ball, I feel like I have a foreign object, I feel like a sharp knife, and all those expressions that the patient come with, they almost ashamed of talking about it, because the qualification of this pain is so bizarre. So everything that come on top of that in this area of our body. So yeah, this hasn't changed. What is great is when they receive the feedback, first I believe and I listen, and then I inquire more than what they expect. So they come with a very shy, you know, shy to explain things, and I just dig and dig and dig to understand, what is exactly which branch of the nerve would be probably responsible. And when you are talking about the bladder, I think this is something we should do all the time, because that's the name is a bladder diary. So bladder diary would be just recording what time do you drink, how much do you drink, what time do you pee, how much do you pee, and then have a sort of balance, so sum up, and yes or no, do you empty your bladder properly or not? Is that painful or not? Is there so we can do a VIS on the side and say, yeah, out of 10, how much is your pain when you fill up your bladder, and how much is your pain when you empty your bladder? So all of that is important for you, important for us as a therapist. So we need all this information about what is working and what is not. And quite often the pain is sort of overtaking on every function, and then we don't realize that we will have to reorganize the bladder as much as the bowel, as much as sex life, as much as sitting, as much as standing, etc.
Yeah, and it's hard. There's so many layers, and the pelvis is so complex, isn't it? And we are sort of wired differently. So I mean, I remember it took me, just going back to the confidence thing, it took me so long, and you know, we connected so straight away, and I was so confident, and yet still it took me a little while for me to say, look, I've got this denim skirt that I wear, and every time I wear it, I have a better day. And you said, bring it in. I want to see it, you know, which, well, I didn't expect that response. And of course, you just gave me one of the pregnancy belts because it was about the pressure of where the seam was on the damn skirt. So simple, but I don't think I would have ever, you know, confided or told anyone that. But the other thing too that you just touched on there is how much like, I know with my issue, I was so wound up by that 4.5 years. The pain had gone undiagnosed and I was getting worse and worse and worse. And of course, there is a bit of bladder issue, and then there is a little bit of issue at the rectum, and then there's a bit of issue. Like it just manifests, and to just get through all of that, you know, and break it down and decipher each thing. I mean, you are really, you know, brilliant at tapping into people, in their personalities, into their characteristics. And you come across, like, it's empathy and it's care and it's all of that, you know. And for Theo, when Theo was there, you know, it's the room. You know, if a patient walks in with 10 of their family members, you'll address each one of them and their role. Like, you really tap into it. We put a lot of pressure on you as patients, but what is, like, you really, the characteristics, I know you said they're listening, you know, you really are listening, but what are the alarm bells? What are the things that will say, right, if I say this to Soula, she's going to go and do that. But if I say this to someone else, they're not. I need to work it differently. Like, it's so hard for you. We're all so different. We walk in to see you, and we're all so different. How do you approach each, and you know, and then all the layers of all the problems that we have, so complex.
I think I would balance, and I probably do all the time, I would balance the sort of questioning symptoms and
Yeah,
you know,
that's your
just the
leg.
physical medical things, and I would balance that with every event that have been through your life, or trauma, or because we only can cope with pain if we have a resilience, and if we have a strength that is important to find out. So I will try to find that as well, like, as much as I can, try to understand when did it happen, what was the other events, so what was the situation of your life at the time, and the context. So I will try to understand all of this, because this impact how you perceive pain. And what will impact how you perceive pain would be also what you have been through before. So have you been through a car accident in the past with the same sort of fear, and have you been, so all the emotional memories. I approach things in a different way, because I've been trained in victimology, and I've been trained in working with survivors of trauma, and I still work a lot with this aspect. I think that's probably why I will pick on every word you say. And I remember I had a student, and she was so Australian, and she was saying, "Oh, this is awesome," and she was so positive all the time. And I remember saying her, but if you are all the time positive and sort of finish every single sentence the patient is saying, the patient will not talk.
Yeah.
Because it's not just, we are not qualifying. We need to ask, and I need to we need to ask because we need to understand, but because we understand, we can make the patient understand and hold and take the power on their own life and on their own symptoms and etc. So yeah, probably that's a big difference in my approach. Is I think I never have the answer until I have heard everything. Is you really need to have all the indicators about, is that neuropathic pain, is that visceral pain, it impact this, it impact that, how the family can be helpful or not, is that a toxic environment or is that a beautiful environment? So and that will define the aim of the treatment, the demand, so what's the patient wants, and so of course the complaint, and the aim of the treatment, the objective and the goal. So we really need to have a wide, it's clinical reasoning in a way, but it's also a police sort of investigation.
Yeah, but you're touching on your experience there. I was going to ask about your training because it is quite specific, especially the trauma side of it, because there is so much trauma with chronic pain. And, you know, even if there isn't, I didn't have, I wouldn't even call the ball bursting a big traumatic accident. I really don't have a big moment like that in my life. But ongoing chronic pain is, you know, it is traumatic. But you also trained in China, didn't you?
Yeah, so probably why the myofascial syndrome is something known for me is that I was trained Chinese medicine. So I was in China in '86, and I was trained mainly with so cerebral palsy in children, but the traditional management of it. So was a physiotherapy training, similar to acupuncture, full-on training for 2 years. And when I came back, I met now a friend of mine, but he's a psychologist that is trained with drug addiction. So he immediately asked me whether I would work with him to help withdrawal syndrome. So that was people into heroin and cocaine at the time. There was no treatment so no substitute, like methadone was not there at the time, Subutex either. I mean, there was none of this treatment. So the treatment was to lock them in for 10 days in a psychiatric ward, and I was the nice blondie physio coming to do relaxation of the muscle cramp and the muscle reaction of withdrawal. So probably that has helped me to understand muscle pain. I also had a teacher, one of my teachers at school was one of the pioneer in France in pelvic rehab, so mainly continence and post-nut. But I start working with her, and I gathered that I have more and more patients with interstitial cystitis, dyspareunia. I had more and more people with pain as well in the pelvic area. And in common, so those two sort of patients, the one in the psychiatric ward, because yeah, after the drug addiction, the clinic I was working in, they decided to address some of the patients with psychotic problems or self-harm or, like body difficulty with their body, but lots of them with trauma. And lots of the patients I have seen all my life were victim of domestic violence, victim of sexual assault, and I decided at that time, so that would be 98 or 99, I decided to train myself in stress and trauma. So that was more for military training, to understand what is post-traumatic stress disorders and what is exactly that state of what is the reaction that a normal human being will have when they are facing trauma and traumatic events. Neuroscience will tell us very, very soon, but we react to pain the same way we react to trauma. For me, it's same integration, the same, yeah. So
I don't actually even, I rarely use pudendal neuralgia. I often just say chronic pelvic pain is as far as probably I'll go, because I don't feel like pudendal neuralgia really encompasses the whole thing. I mean, there's fatigue in there and there's all sorts of things in there. Is it just trauma? Is it pain trauma? Is that what we're going to change the word?
It's complicated because I don't want to label and to put every person in the same bag. So I would say within pelvic pain, there is very different experience and very different stories. So yeah, it's pudendal neuralgia would be really specific because this nerve has 3 branches, and the branches are going for women to clitoris, perineum, and rectum. So it will lead to have patients that complain of 3 different type of symptoms, we would say, and they will also see 3 different type of doctors, even 4, because there will be the neurologist or the rheumatologist, and there would be a gastroenterologist, and there would be a urologist, and there would be a gynae. And so they get lost, those patients with that. So this is pudendal neuralgia would be, or as similar situation would be very difficult because patient would have been through this and through so different doctors, and
like me.
whereas they
that's where I went all around the world. I eventually got there. Yeah, I remember,
and that's the same for a man, because if you look at man with pudendal neuralgia, that's their so it's a we have the clitoris pain, but there would be penile pain, and there would be pain with ejaculation and pain in the testicle and pain, and they just don't know where to go either. I mean, it's really a nightmare.
Yeah.
So that is really a difficult area of pelvic pain. Compared to there would be just vulvodynia would be a bit more simple, I would say. Everything which is to do with surgeries, or like post-surgery pain or whatever, would be a bit more focused, a bit more logical, or just after child delivery, or etc. So pelvic pain is huge, and as a physio you need to be trained in so many things. Like, you need to be good at obstetric, you need to be good at understanding urology, you need to be good at understanding gastroenterology, you need to be good at understanding sexual disorders. It's just like
I like the way you called it logical. You separated because they're totally illogical. Yeah, that's how I feel like I'm definitely in the illogical box, because it just fires, on all different cylinders and causes, it's just a big mismatch, which, I've learned a lot about. But how are we going to train people? How are we going to train professionals or to manage pain? What is the training they need? I mean, we know GPs, if you're training for a GP, I think you get, is it hours, I think, to focus on chronic pain. I mean, but we have pain specialists now, and that's a really fantastic, obviously a wonderful, wonderful thing. Tame the beast now. You hope that gets out into the world and it starts to educate people about pain, and it's not what we think it is. But I know when I speak to people, they they'll always say it's not like it's not like yours. It's real pain. And I keep getting all these sorts of things. There's a brand about pain. There's an identity with pain. Most people who get chronic pain don't think it's anything like what they've heard before. I know it wasn't for me.
I think what we need is specifically to train people in pelvic pain, because there's a lot of people trained in pain, but that would be back pain. that would be neck pain, that would be whiplash, that would be
more muscle, more
and very musculoskeletal. And yes, of course, it would be a car accident that was absolutely an horrific scene, and there is a context as well. And there would be you lost your job, and there's another context, and etc. But pelvic pain has a very specific sort of endeavor. You will have your life with your partner is totally impacted at many levels with sexual issues. You will have your bladder function, your eating function, your like the basics, and that's probably why we need to really train doctors, but also physios and nurses and midwife, and on this specific. It's an entity. It's really important to understand that we can't question about pelvic pain without questioning visceral pain and all the organs that are in this in this tiny little spot. Like we really need to be trained for this. And it's a pity because then it's only pelvic floor physiotherapists that would be trained, and that's a little tiny group of physiotherapists. So we really need to train all the physiotherapists or all the doctors at the general doctors to be aware of how this is so specific, because there is training in pain, of course, and there is now pain doctors and there is a specialty, but there you will notice that pelvic pain clinics are very rare, and they are just a little bit inside a chronic pain clinic. So there would be a little bit of that clinic. Like multidisciplinary clinic need to really be open up everywhere.
Yeah, well, that's what, I mean, after seeing my pain specialist, I think now looking back from my GP, I should have really gone to to obviously physiotherapist, and then, a pain clinic like that would have probably avoided, because what you want to do as well is sort out everything you can before surgery, before that really invasive. So why wouldn't you just go to a pain clinic? Why wouldn't you? I mean, I somehow ended up in this mechanical investigation, and I was getting the injections, but it was all cortisone. And of course, in 3 days, there was, I was back to how I was. It wasn't, I have 3 amazing days. And it took a long time for someone to realize that meant nerve pain, that it wasn't mechanical pain. It took one fantastic orthopedic surgeon to realize that and send me to Professor Teddy. But it just still seems like the patient will land at the GP, and unlike heart or your eyes or your ears or whatever else you might have, there's a path, and you're going to go, okay, you're going to go to that person, and this is the treatment, and it's all outlined, and you have this path. But the patient, the pelvic or the pain patients, they have to find everything that doesn't work for them before they find what does. It's this massive process of elimination. It seems backwards. We know it's complex, but it seems really backwards for people who have chronic pain.
I think what you just say about having your GP immediately taking the history and saying, this is about pelvic pain, let's go to this clinic. They will have the gynae, they will have the pain specialist, they will have the physio, and they will have everyone that we need. I think that's the way. There is absolutely, it's otherwise we've got patients that are going in a place and then another, and then one doctor will say this and the other one will think, oh no, this look like more this. So I think that would be interesting if we get to a good pain specialist able to be trained in this and leading the way, or leading the research on exploration and which MRI and what.
There is somehow an MRI that maybe can see nerve. There isn't though, is there? There isn't.
Well, you have to do an MRI. No, not just to see there is something, but to see there is not something. So we're looking with MRI,
That's
we are
what I'm
looking
talking
at
about, the process of elimination. You find out
yes,
everything you don't have before you find
yeah, but we need to be sure, and usually that's the thing that I will look when patients are coming, is just what MRI they have, and because you need to have the certainty that there is nothing, like a cancer or a mass or whatever that is creating the pain. So of course we need to have all those exploration done. That would be the first management. Everything seems to say that it's nothing to remove, or nothing. We have to tell ourselves, yeah, this is a logical behavior of our body. There is a pain process, and because there is a pain process, there is a system of defense, and because there is a defense system, the body will tense up, and because there is muscle tense up, it creates more pressure, and because the nerve in charge of the pain is a pressure nerve, it will capture more pressure message, so it will capture more information about pain, and so it will trigger more pain reaction. and we're going to look. So if we are able as therapists to explain to the patient that hypersensitization is a condition, that the pain itself creates a condition, then we explain to everyone that we need to trigger with many practitioners and many entry, we need to trigger this pain process.
It's so hard to believe that. Like, I listened to that now. I was about to say to you, so many people do write to me, and what did your physiotherapist do when she switched off the pain? You did that sort of, you applied the pressure, and I was going to say to you, what message would you send them? But I think you really just, in that explanation of how pain becomes so much of a knot, speaking in patient language, this massive manifestation that just keeps on, and that's how I felt I was in a big knot. I also described the first implant, I described it as there was a glacier, and they just popped, it was like a chisel, and it cracked it, and I was able to then tackle it piece by piece by piece. You're debilitated. I mean, it consumes you. It stops you from the function. I think the function side is the shocking bit, when things start to really go out of whack, and that, you're looking at the sun and you're getting tired, and like all those things are hard to explain to someone.
You said two important things. One is this knot. I am a sailor, and when there is, like there would be a lot of knots. But the thing is that you have to be very patient with the knots, because you have to remove this and then put it back into this and then pull that one bit, and then this is exactly what I would be doing with my patient. We'll try to understand this little bit, try to open up this, okay, it's working, or go this way, or okay, this is working. So that's exactly why it's so complicated. We need to, there is no protocol. There is no 1, 2, 3, 4, 5. There is really what the patient can cope with, how, what are the, so it's an adaptation, both from the patient perspective and from the therapist perspective. And the second thing you were saying was the fact that we have a situation where the patient is lost and is constantly looking for solution, and etc. And I really think that the role of the physio is to make it simple, and to work with silo, and to just say, okay, we know that pain is overwhelming. We know that you're not like before. But what you are now today, on the day I'm talking with you, is that your bladder is doing this, your bowel is doing that. So it's a really stick to the fact and reorganize everything, and don't think of the past. So just go with what is today. if we were, what we are doing at the moment with the situation of lockdown and with the situation of COVID is exactly that. Every day we have a new sentence. No, you can't go out. Yeah, you can do this. No, you can't do that. So we constantly adapt to a situation. We're not thinking of, oh, but last year I was doing this and this and this. So that's exactly what we need to do with pain. It's a context of prison. It's like being jailed in our body. And we are trying to free up this part, this part, this part, this part, and we go forward. So the help of a good team would be to say, okay, this muscle is really one of the obstacles. Let's put some Botox in that one. Or your brain is too anxious. Let's put some medication for anxiety. Or you need to do some hypnosis or EMDR because you have too much memories and flashback, and like so. Allegedly, with what we have understood from the first sort of assessment or the second assessment or the third assessment, we will progress through. But what is really important is to have the sensation that the patient is not comparing with the past. So just, stay to the fact, and what we can move on is important.
And it is ever changing as well. As you move through that, it changes. I know that, yeah, with me, it's always changing. Would I still have pudendal neuralgia today? Is that what I have?
No.
No? Good. I remove this.
Oh, I know. I there's something. Yeah, there's something I like.
Get rid of it now. Throw it away. So you had the key. You didn't tell me.
Soula, I don't want you to think that you have pudendal neuralgia all your life.
That's great. Thanks for that. My brain needed to hear it.
You had pudendal neuralgia, and now you have the pain.
Yeah.
Work a lot with Theo, because Theo was coming to our sessions, and I also probably had reassured him about what we were doing and what would be the progress and etc. And now I have taken, well, probably it's now something I'm doing every time I'm taking the husband or the wife, or when it's to lesbian or whatever, I would take the partner. And if I don't have a partner, I would take the mom or the daughter or the son or whoever, the neighbor.
Yeah, someone.
And most of the time, I would sort of train. The two very important thing is, it's easy for me to teach how to do an abdominal massage or just a colonic massage, just how to have your bowel being a bit more relaxed. It's easy for me to teach how to relax the sacroiliac joint and how to relax some of the piriformis muscle. And so I would use the person that would be my assistant in a way, because then we know that when there is a crisis, when the pain hits, someone is there.
There's relief too.
Because with the pain, there is this problematic thing of waiting for the appointment with the physio or the appointment with the doctors, and you're suffering and you're suffering and you wait and you wait, and this waiting time is actually anxiety, and it builds up the pain. So we need to have some sort of management, home management, and I'm trying to do that a lot,
that really
and it's
worked
working.
for me. That worked for me. Remember, you showed Theo how to apply the pressure. I'm not sure you called that a specific technique. What was it called?
No, it's just a relaxing sacroiliac joint, and sort of it's a 3D relief. So it's a technique that doesn't have a name. It's just a logical way of opening up and releasing obturator internus piriformis muscle. So it's just trying to open up and relax this area.
And it did. I would have a break. That would give me a break. It was amazing.
Exactly.
Yeah.
Exactly. And one break would be this. The other break would be to have pillows and pillows and pillows and organizing position and posture and giving a few solutions. Sending all my patients in the water. I want everyone to be floating in the water and just
the
relaxing.
floating is good, but getting out of the water and walking, obviously, for me, I couldn't. It was so heavy, and getting out.
There was the problem of the was the ladder. Every time you were climbing the ladder, so we need
the weight.
Yeah, because when you climb the ladder, you have to move your hips again. And the other thing would be sexual pain. So sexual pain. Nowadays, I really take the husband or the partner in, and I will discuss this as a sport problem. It's a sport problem. It's not a sexual problem. So it's pain in a sexual area, but it is pain. So the dealing with that would be the same as if you have a shoulder pain after any injury, sport injury. And if you are a basket player and you have a sport injury, and I'm your physio, I would give you exercise progressively. So I will pace your exercise until you can go back to your tournament or you can go back to your champion you are playing. So if we use this metaphor and we apply it to intercourse, we will have to think of, okay, we need to pace something. What? So it could be the diameter. It could be the penetration, so that we will go 1 centimeter by 1 centimeter. It could be the position, the angle. It could be, and we will have to work with the couple. We will have to work with the patient and the husband and the wife and the etc. about the problematic impact of the chronic pelvic pain with sexual intercourse. Yeah. And this is something not a lot of people want to talk about because that's the taboo, and that's and probably if I have an advice to give to physiotherapists, it's just for us. It's easy. It's a sport retraining. It's nothing less, nothing more. It's just how we present that to both patient and the partner.
Yes, I feel
this is one of the most important aspect of it. That's why there is shame, and that's why pelvic pain is so different, because it touches bladder, so urinary function, bowel, and so all those very shameful bits where you don't want to talk to anyone have to be have to be trained, have to be repaired, have to be voila.
I think so. Like when you brought me the belt, voila, you said. You changed so much. Just one little voila.
I want the voila. If I would have a magic wand, I would. I love to. I love miracle.
Wouldn't that be fantastic? Look, look, I don't know. I get more and more confused. I feel honestly, the more we learn, the less we know. That's from my patient perspective. I just read and read and read and learn and learn and learn and do all this, and I just feel like, we're never going to get it. And then other times I think it's going to be really simple. It's going to be one thing that just goes click, and it helps a lot of people. But I go from one.
Well, advocacy helps thousands and millions of people, because you are, you can help just people to understand and to talk and to feel that they're not alone. And just that is enormous, because you understand what they are talking about, and they understand that there is someone who can understand.
Yeah. You're so alone in pain, aren't you? You really are totally alone. A summary, it's meant to be something that a professional will glance at, because I just didn't want to come into the appointment, and people didn't know who I was. They didn't know I had a professional career, and I had done a lot of work, to walk in and say, hi, Anne Florence, and start, like 4.5 years, even if it's 6 months or a year of appointment, it's such a stress and a trauma. And even now, like, I just make notes before my appointments, and I walk in, and the GP or, my pain specialist will say, oh, Soula, I see you've got this on your mind, or, oh, Soula, you've been doing this. And it's, it feels like you land in the second or third appointment, not in that first where you have to get
the repetition of the first.
Yeah, it's really hard, that first part. So you end, and the professional knows you. Hi, how are you? So, are you been doing this? How's that going? Are you worried about this? Here's some information on this, the information, and that way. So I sent you the link. I gave you private access, and you're going to see my history. But if I have the appointment and I don't really like you, or I'm not going to see you again, I can retract that link. So I'm always in control. And it's there for me to sort of, I'll probably, ahead of the appointment, I'll contact reception and say, here's a link, can you please make sure the doctor gets this, or the physio gets this before I come in. I just, that's it, that's the whole thing. But the patient signs up, I think it's like $25, $30 a year. They can make all the health summaries. I made one for when I had my spinal cord stim. I had a separate one, and I could document those things and send my notes to Nick. So, I came to Queenscliff, and I was so worried here. I was so far away. I was so used to being next to the hospitals in Collingwood. And, I had to just all those stitches, you're coming back to a country town. And so what happens is you send him the link. So I'll see when you last checked my summary. I can see when you saw it. And so when he looked and I saw that he had clicked the link and he didn't contact me, well, I felt comfortable that I was fine, because I thought if he read anything that was alarming, he would have called me. So it's a really nice communication between the appointment as well. Look, it can do a lot of things, but it's just the very start, really. I'm developing it on my own. But it's good. A lot of people find it's their backup and their safety net. And of course, the other thing I didn't know was that you don't own your history, your GP. You don't own your history. I didn't know that. So that was tricky. So, when I met the GP down here, I thought, oh my God, if I have to repeat 9 years of pain. But I just sent her my health summary, and it was great. It was really good. So
it's a brilliant and a logic idea. It's just difficult for patient, because there is a temptation, which is to write your diary, or
I didn't want it to be a diary. That's the thing.
No, but that's what I mean. And then professional will not look at diary, because we don't have the time.
Never make it your pain, not my pain. Don't call it mine. Don't adopt it. And that's another thing with the pain diary. You constantly, it makes you go back there. It's one thing I never liked about even the idea of keeping a diary, because then you've got on your mind, how am I feeling now? What am I doing now? Has it settled? Has it? So there's no way that's ever going to make it into the health. Well, just brief.
That is an important point. The point is not to know how much pain we are in, but it's to know that there is a limit above which the pain will go crazy. So we need to have management ideas. So let's say I am 2 out of 10. Oh shit, I'm 3 out of 10. Oh, immediately I put some ice, or immediately I ask my husband a massage, or immediately. So what is important in pain diary is the management, not the pain diary.
Yeah, the awareness of it. Yeah, that's what I love about Protector Meter and the backpack and the DIMS and the SIMS. So good. It's so good. That's how I've managed to get there, ping, I've got those. Okay, not 2 walks today, we're going for 1 walk. I want to have work that out.
Oui.
Oh, okay. Thank you so
You
much.
can develop, you should develop a Excel chart that help two things. First, the
You give
recording.
me another job.
Yeah, yeah. But that would be interesting, because what I often look at is the management, the self-efficacy. So the self-efficacy is something that you could measure when you see patient constantly under 3 out of 10, 2, 3 out of 10, and if they go 4 up, they have immediately a reaction towards pain, not towards their life, towards pain. And that help a lot. So it could be a good idea.
Yeah, it could be something that sits on there. I mean, you can upload any file there. So if I'm working with you and you've got that Excel file, I can upload it and you can see it. Yeah.